Hello everyone, I am myself Dr. Rajesh Gubba. In this particular session, I will be discussing a very important topic in the cardiology, that is the aortic regurgitation. So it is a clinical condition which is characterized by regurgitation of the blood from aorta into the left ventricle during the diastole. Now the etiology of the aortic regurgitation, if you see, we classify that into mainly two. That is, the aortic regurgitation, it can occur because of the pathology within the aortic valve itself, that is the primary aortic valve diseases, or this aortic valves, they are present within the aortic root. So if there is pathology within the aortic root, that also can lead to the development of the aortic regurgitation. Or sometimes, like you take in conditions like ankylosing spondylitis and as well as syphilis, there can be combination also, where there can be pathology within the aortic valve and as well as the aortic root as well. Now let me discuss what are the aortic valve diseases and what are the aortic root diseases which will be responsible for the development of the aortic regurgitation. So the aortic valve diseases, if we see, that is rheumatic, infective endocarditis, some congenital causes like bicuspid aortic valve, myxomatous degeneration, radiation, trauma, syphilis and ankylosing spondylitis. These are the aortic valve diseases that will be causing the aortic regurgitation. So again, each and every etiology I will discuss in detail why and how are they causing the aortic regurgitation. Now you take the aortic root diseases causing aortic regurgitation, that includes the aortic dissection, Marfan syndrome, bicuspid aortic valve, hypertension, aneurysm and as well as the medial degeneration. Now let me try to discuss each and every etiology, what is the mechanism of this causing the aortic regurgitation. So first let me take up the discussion of the rheumatic disease. Now in case of rheumatic disease, there will be thickening of the aortic valve, there will be deformity within the aortic valve, and there will be also shortening of the individual aortic valve cusps. So if you take, there are totally 3 cusps within the aortic valve. So there will be shortening of the individual aortic valve cusps. Now because of the development of this abnormality, that is thickening, deformity and as well as the shortening of the individual aortic valve cusps, these particular changes, they prevent their proper opening, right? Thickening, deformity and as well as shortening of the individual aortic valve cusps, they prevent the proper opening during the diastole, and they also prevent proper closure during the diastole. So because there is no proper closure during diastole, this can cause the development of the aortic regurgitation. And what you have to remember is, isolated rheumatic, in the sense, the rheumatic disease causing only aortic regurgitation is actually a rare phenomenon. Most of the times this rheumatic causing the aortic valve involvement will be associated with mitral valve pathology, right? So along with mitral valve, there will be involvement of the aortic valve for the development of aortic regurgitation in case of the rheumatic. Then followed by that, we have some congenital causes which are responsible for the development of aortic regurgitation. That includes bicuspid aortic valve, fenestrations within the aortic valve, membranous subaortic stenosis which is responsible for the development of aortic regurgitation. Now you take the bicuspid aortic valve. This bicuspid aortic valve may develop predominant aortic regurgitation, and 20% of these patients will require surgery, right? 20% of these patients, they will require the surgery when between 10 and 40 years of life. So bicuspid aortic valve, it can cause aortic stenosis, and because of incomplete closure during the diastole, it can cause the aortic regurgitation as well. And another important congenital cause for aortic regurgitation is fenestration. So the fenestrations of the aortic valve, this will produce the development of the mild aortic regurgitation. And next important etiology is the presence of membranous subaortic stenosis. Presence of membranous subaortic stenosis will result in high velocity systolic jet, right? It will cause the presence of the high velocity systolic jet. Now this high velocity systolic jet, that will lead to thickening and as well as right? It will lead to thickening and as well as the scarring of the aortic valve. Now, because of thickening and as well as the scarring of the aortic valve leaflets, there will be incomplete closure of the aortic valve, and that will lead to the development of the aortic regurgitation. So, these are the three important congenital causes which can cause aortic regurgitation. Few more valvular pathologies causing aortic regurgitation are the myxomatous degeneration of the aortic valve. See, in case of myxomatous degeneration, there can be development of even mitral valve prolapse. Even here also, there will be prolapse of the aortic cusp, right? Prolapse of the aortic cusp. That will lead to the development of progressive chronic aortic regurgitation. And this myxomatous degeneration causing the development of aortic regurgitation, it is also associated with 15% cases of the ventricular septal defect, right? It can be also associated with the development of, it can be associated with ventricular septal defect. And next is the infective endocarditis causing aortic regurgitation. Remember, this infective endocarditis, it will cause the development of friable vegetations over the aortic valve. That will cause the pathology within the aortic valve where there will be incomplete closure during the diastole. But most of the times, this infective endocarditis causing aortic regurgitation will occur on the valves which are affected by the rheumatic heart disease, or the valves which are congenitally deformed valves. On that, the infective endocarditis vegetations can develop, or even the normal valve can also get affected in case of the infective endocarditis, right? So, that is about the infective endocarditis causing aortic regurgitation. Next is the syphilis and as well as the ankylosing spondylitis. The syphilis and as well as the ankylosing spondylitis, that will cause the scarring of the aortic valve leaflet, and there will be retraction of the aortic valve leaflet. So, scarring and as well as the retraction of the aortic valve leaflets. So, scarring and as well as retraction of the aortic valve leaflets, remember, in syphilis and ankylosing spondylitis, it is not only the aortic valves which are being affected, even the aortic root, it is actually the primarily aortic root disease. Then subsequently, even the valves are also affected in case of syphilis and as well as the ankylosing spondylitis. Next is the traumatic rupture. This traumatic rupture, it will be causing the avulsion of the aortic cusp, and this traumatic rupture, it will be responsible for the development of the acute aortic regurgitation, and even your infective endocarditis is also responsible for the development of acute aortic regurgitation. But this traumatic rupture causing the avulsion of the aortic cusp causing aortic regurgitation, this is uncommon cause of aortic regurgitation. Okay. So, remember, in patients with aortic regurgitation due to primarily valvular disease, there will be also dilatation of the aortic annulus, right. So, once there is dilatation of the aortic annulus, subsequently there can be worsening of the aortic regurgitation, right. So, these are the primarily valvular pathologies causing aortic regurgitation. Now, then followed by that, you need to be very much aware of the primary aortic root diseases causing aortic regurgitation. So, here the aortic valves will be absolutely normal, but there will be marked aortic annular dilatation, right. There will be marked aortic annular dilatation, that is basically an aortic root disease that will be responsible for the development of aortic regurgitation, that is the marked aortic annular dilatation. Now, what are all the various etiologies that will be causing the aortic root diseases, right. So, I have just shown you this table in the beginning of the etiology also, that is medial degeneration of the ascending aorta, Marfan syndrome, which is a connective tissue disorder, then annular aortic ectasia, osteogenesis imperfecta, and as well as the chronic hypertension. Remember, how does all these etiologies will be responsible for the aortic regurgitation is that all these will cause the widening of the aortic annulus, right. All these will cause the widening of the aortic annulus. Okay. So because of this widening of the aortic annulus, that will cause the progressive aortic regurgitation. And whereas you take the aortic dissection causing aortic regurgitation. So this aortic dissection, if there is retrograde, right, if there is retrograde dissection of the aorta, this retrograde dissection of the aorta, it involves the aortic annulus. Okay, so once there is involvement of the aortic annulus, there will be dilatation of the aortic ring or root that will cause the aortic regurgitation. Now you take this aortic regurgitation which is caused by syphilis and as well as the ankylosing spondylitis. I have said you this in the beginning also, right? In both of these conditions, there will be cellular infiltration and scarring of the media of the thoracic aorta, and that will be causing the aortic dilatation, that will be causing the aortic aneurysm, and there will be also these will lead to the development of the severe aortic regurgitation. And what did we discuss? That syphilis and ankylosing spondylitis will also cause primary valve pathology causing aortic regurgitation, whereas the aortic root pathology is that they will cause the infiltration and scarring of the media of the thoracic aorta. Now if you take this particular syphilis, the individual will also develop the angina. Why is that there is development of angina with syphilis? Remember, in case of syphilis, there is involvement of the intima, right? There will be involvement of the tunica intima of the coronaries, and particularly at which point of the coronary? That is the coronary ostia. So because of the involvement of the coronary ostia, intima of the coronary ostia, there will be narrowing of the vessel wall, right? There will be narrowing of the coronary, and because of the narrowing of the coronaries, there will be decreased blood supply to the myocardium, and that will be responsible for the development of myocardial ischemia, right? So that is about the aortic regurgitation caused by syphilis can also cause myocardial ischemia, and due to which there will be development of angina. Now this aortic regurgitation is also seen in case of the large vessel vasculitis, that is Takayasu and as well as the giant cell. See, here also there can be development of the aortic aneurysm formation, and because of this aortic aneurysm formation, that can progress to the development of the aortic regurgitation. Now these are all the etiologies causing the AR, that is primary valve pathology and as well as the aortic root pathology. Now if you observe the clinical features in these patients, right? So the clinical features, what you have to understand is that primarily due to aortic valve pathology caused by rheumatic fever causing aortic regurgitation, this is more common in females rather than males, right? Primary valvular pathology caused by rheumatic fever, it is predominantly seen in women rather than men, whereas the aortic valve disease due to some other etiologies except for rheumatic fever, they are more commonly seen in men compared to that of women. And what will be the clinical features? There can be development of an acute AR, there can be development of chronic AR. Now which is a medical emergency? It is the acute severe regurgitation, that is a medical emergency. What will be the etiology? I have already discussed, that is infective endocarditis and trauma, and as well as the aortic dissection which is progressing in a retrograde direction to the aortic annulus causing aortic root dilatation causing aortic regurgitation can also cause the acute aortic regurgitation. Now what happens is, whenever there is acute aortic regurgitation, so there will be increase in the LV end diastolic volume, right? Because the ventricle will be getting the blood from the aorta and at the same time from the left atria. Now this particular ventricle, once there is increase in the LV end diastolic volume, because of both of these flow, the ventricle is unable to tolerate that increased volume. So in acute state, the LV cannot dilate, right? So at a time if large quantity of the blood is entering into your ventricle from both atria and as well as the aorta, the left ventricle did not get sufficient time to get dilated. So now because of increase in your LV end diastolic volume, there will be increase in the LV end diastolic pressure, and this increased LV end diastolic pressure that will be reflecting back into the atria. So there will be increase in the left atrial pressure. So once there is increase in the left atrial pressure, that will cause increase in the development of the pulmonary capillary wedge pressure. Once there is development of increase in pulmonary capillary wedge pressure, and that will result in the development of pulmonary edema, and that can make the individual to develop acute onset dyspnea. Right, that can make the individual to develop the acute onset dyspnea. Okay, so these are the features of the acute severe aortic regurgitation, which can happen secondary to infective endocarditis, trauma, and as well as the aortic dissection. So this pulmonary edema will not only cause the acute onset dyspnea in these individuals. So what will happen to the cardiac output? Because there is an acute regurgitation where the LV is unable to handle that large quantity of the blood, there can be development of the LV dysfunction, thereby the cardiac output can get affected. So these patients subsequently can also develop the cardiogenic shock. So remember, these patients, they require an immediate surgical intervention to come out of this event of the acute AR. Whereas you take the chronic aortic regurgitation. Chronic aortic regurgitation, the story is slightly different. What is that? These patients, they have a long latent period, right? They have a long latent period, and these patients, that means the regurgitation which is happening from aorta to the left ventricle is very mild initially. So that is the reason why left ventricle is able to tolerate that mild volume overload. So they will have long latent period, and these patients, you know, they remain asymptomatic, right? They remain asymptomatic as long as 15 years they are asymptomatic. Then after being asymptomatic for nearly around 10 to 15 years, what will be the earliest manifestation? The earliest manifestation is uncomfortable awareness of the heartbeat, which is nothing but the palpitations. Now this palpitations, it mainly occurs on lying down. Okay, so this will be the earliest manifestation. Now what could be the reason for the development of the palpitation is the sinus, development of sinus tachycardia during exertion, and as well as initiation of the premature ventricular contracture. These two can produce the uncomfortable palpitations, right? These two can produce uncomfortable palpitations as well as the head pounding. So why there is, like, you know, premature ventricular contracture? The reason is that whenever there is the aortic regurgitation, there is, or there will be maximum LV dilatation. Now this maximally dilated LV, that can throw a stimulus wherein there can be development of a premature ventricular contracture, and that will give rise to, you know, the symptom of the palpitations. After the palpitation, the next important is the exertional dyspnea. Why is that you are getting this exertional dyspnea? See, again the same story. At one point of time, there can be development of left ventricular dysfunction. So once there is left ventricular dysfunction, there will be increase in your left ventricular end diastolic pressure, increase in left atrial pressure, increase in pulmonary capillary pressure causing edema. So that will cause the exertional dyspnea. Basically, another point is during exertion, there will be increase in the heart rate, right? So once there is increase in the heart rate, so what will happen to the diastolic filling time? The diastolic filling time from the left atria, diastolic filling time from the left atria will be reduced. So that also can cause increase in the left atrial pressure, because the volume of the blood which has to come to the left ventricle is not coming adequately. So that will increase the left atrial pressure and subsequently pulmonary capillary pressure and subsequently causing edema, right? And the other features are, so because once there is development of the left ventricular dysfunction, there will be diminished cardiac reserve or diminished cardiac output, even that can make the individual to develop fatigue. So this is another important complaint. So one is palpitation, the other one is exertional dyspnea. Next is the anginal chest pain. And remember, the anginal chest pain that you see in case of the chronic aortic regurgitation, it will be there in the absence of the coronary artery disease, right? Now, this can be seen even in young patients. Now, what is the mechanism for the development of the anginal chest pain, right? So this anginal chest pain, it will occur during rest and as well as during exertion. Now, what is the mechanism? So remember, in aortic regurgitation, right, what is happening to the LV volume overload? There will be increase in the LV volume overload. Okay, so that means the left ventricular activity gets increased, right, because of regurgitation. Now, once the left ventricular activity increases, that is when the load on the left ventricle is increasing, there is also increase in the myocardial oxygen demand, right? But what is happening? The aortic regurgitation is the one which is occurring during the diastole of the ventricle. And at the same time, what you have to understand is that the myocardium, right, the myocardium will receive the blood supply during the diastole, right? Myocardium will receive the blood supply during the diastole. But during the diastole, the blood, instead of going to the myocardium, it is entering into the LV. So because of that, what can happen? There can be myocardial ischemia causing angina, right? So the concept is very simple. So during aortic regurgitation, the blood, instead of going into the coronaries, going to the myocardium, during aortic regurgitation, the blood is going back into the LV, thereby compromising the myocardial perfusion. Thereby, the individual can have an ischemia causing angina. But as such, there is no coronary artery disease, but still there is development of the ischemia, right? And these patients, they very significantly have the nocturnal angina, right? Nocturnal angina is a very classical feature of the aortic regurgitation. Now, why is that the nocturnal angina is very classical? What you have to remember is that during night, whenever we sleep, there is increase in the parasympathetic nervous system activity. Once there is increase in your parasympathetic nervous system activity, what will happen to the heart rate? There will be bradycardia. So once there is bradycardia, what will happen to the time of diastole? So there will be increase in the diastolic time, right? So once there is increase in your diastolic time, there will be more and more aortic regurgitation. So more and more aortic regurgitation, there will be increase in the left ventricular volume overload. And at the same time, what is happening to your coronary perfusion? The coronary perfusion is getting reduced because much amount of the blood is entering into your LV. So during night, the myocardial oxygen demand increases, but the supply decreases. That will lead to the development of the nocturnal angina, right? And these anginal episodes, they can be prolonged, and you have to remember that this particular anginal episodes of the aortic regurgitation, they don't respond to the nitroglycerin, right? They don't respond to your nitroglycerin. Nitroglycerin, what it can cause? It can cause coronary artery vasodilatation. But what is happening in aortic regurgitation? Even though there is like coronary artery vasodilatation, the blood which has to go into the coronaries is not going. The blood is returning back into your LV rather than into the coronaries during the diastole, and thereby there is no response to your nitroglycerin at all. Now, as the severity of the chronic aortic regurgitation increases, that is later in the course, so there will be initially left ventricular failure that can further progress to the development of the right ventricular failure. So these individuals, they can develop the congestive hepatomegaly, right? So later in the course, there will be development of the congestive hepatomegaly, that is the cirrhosis will be seen, and that will cause the development of the ascites. And subsequently, there will be also development of the pedal edema. Because, so why is this hepatomegaly and as well as the pedal edema? That is because of development of right ventricular failure. So these are the clinical manifestations in acute AR and as well as chronic AR. So remember, in acute AR, sudden onset dyspnea, where it's an immediate emergency where they require an immediate surgery. Whereas chronic AR, the earliest manifestation will be palpitations, then exertional dyspnea, and there will be also development of angina. And nocturnal angina is a very important feature here. Now let us discuss about the examination findings in patients with the aortic regurgitation. So if you see the physical examination findings, the peripheral signs in case of aortic regurgitation, I will be telling you all these. They are very common in case of chronic aortic regurgitation, but not in case of the acute aortic regurgitation. So, and more is the number of the peripheral signs, severe is the aortic regurgitation. And these peripheral signs, right, there are multiple peripheral signs. They are present in case of chronic AR, but not in case of the acute AR. Very important point. Now, what is the basic pathophysiology for the development of this peripheral signs in case of the chronic AR, and why is that you don't have in case of acute AR? Let me try to discuss. So, in aortic regurgitation, what is happening? There will be increase in the LV end diastolic volume. And once there is increase in your LV end diastolic volume, what will happen to the stroke volume? The stroke volume increases, right? And because of which there will be increase in your cardiac output as well. So in the periphery, right, starting all the way from the tip of the finger to the lower limbs, there will be increased volume of the blood that will be ejected during the systole. But again subsequently, right, subsequently during the diastole, what will happen? During the diastole, what can happen is the entire blood from the aorta is returning back to the ventricle. So there is diastolic runoff, right? There is diastolic runoff, and because of this diastolic runoff, there will be decrease in the volume of blood in the periphery. So that will give you a picture similar to that of a collapse. So during systole, there will be rapid upstroke. During diastole, there will be diastolic collapse of the peripheral circulation. So that will give rise to the peripheral signs in case of the chronic aortic regurgitation. But whereas you take in case of the acute AR, in acute AR, the left ventricle is not in a position, right? It is not in a position to handle the volume overload. So when left ventricle is not in a position to handle the volume overload, directly the individual will land up in pulmonary edema. You don't have increase in the stroke volume, right? So there is no increase in stroke volume in case of the acute AR, but in chronic AR there is increase in your stroke volume, and during the diastole there is diastolic runoff in chronic AR. So you have a rapid upstroke followed by a collapse, but here there is no increase in your stroke volume. So that is the reason why you don't have that rapid upstroke. Okay, so that is the reason why you don't have peripheral signs in case of the acute aortic regurgitation. Now let me tell you, in case of the aortic regurgitation, that is chronic aortic regurgitation, these peripheral signs, they are seen all the way from the tip of the finger to the lower limbs. Now we will try to discuss all these in a very systematic manner. First important sign is the Quincke's sign. Now how is that you will demonstrate the Quincke's sign is, you need to apply, right, you need to apply the pressure over the digits. Okay, so once you apply the pressure over the digits, what can happen? What can happen is you will be able to observe the pulsations over the nail bed. Okay, so what is that pulsations? You will notice that there is redness and as well as blanching of the digits whenever you apply the pressure over the digit, you can observe that over the digit, that is over the nail bed, there is redness and as well as blanching. Redness is the one which you see during the systole of the left ventricle. Blanching, that is pallor, is the one which you observe during the diastole of the left ventricle, because during systole there is increase in your left ventricular stroke volume, and during diastole there is diastolic runoff, and thereby there will be blanching of the nail bed. So that is about the Quincke's sign. So you have alternate redness and as well as the blanching over the nail bed. Next is the prominent digital artery pulsations. So what you have to do is you need to catch hold of the patient's tip of the fingers with your tip of the fingers. Once you catch hold like this, what is that you will observe is, so you need to hold the fingers of the patient. So once you hold, what is that you will observe? You will observe prominent digital artery pulsations. So this prominence will be there during the systole of the left ventricle because of increase in your stroke volume. Subsequently, what will happen is there will be collapse during the diastole because of diastolic runoff. Okay, so that is what is your prominent digital artery pulsations. Next is the characteristic pulse. This pulse, like what you have, is the water hammer pulse, which is also called as the Corrigan's pulse, right, which is also called as the Corrigan's pulse. So if you take this water hammer pulse or Corrigan's pulse, how is that you examine this, right? How is that you examine this? So initially, you need to palpate the radial artery, and then you need to raise the arm of the individual, and then you need to palpate this radial artery. What is that you will observe is, you will notice that there is rapid upstroke during the systole of the left ventricle, and then you will observe the collapse of the radial artery pulse during the diastole. And why is that due to? That is due to diastolic runoff. And what is the reason why you need to raise the arm of the individual is, once you raise the arm of the individual, you are aligning the radial artery, brachial artery, axillary artery, right subclavian artery, right brachiocephalic trunk, then arch of aorta, ascending aorta, and then directly into the left ventricle. So once you raise the arm, there is proper alignment of the radial artery directly into your left ventricle. So during the diastolic runoff, there will be rapid collapse. Okay, so that is about water hammer pulse or the Corrigan's pulse. Next is the locomotor brachialis. So you can observe this tortuous and highly pulsatile brachial artery. So the differential diagnosis for locomotor brachialis is atherosclerosis also. Now what is that you will observe in locomotor brachialis? That is, during the systole, you will observe the prominence of the brachial artery pulsations, and during the diastole, you will observe that there is collapse of the brachial artery pulsations. Right, during the systole you have the prominence, and during the diastole you have the collapse of the brachial artery pulsations, and that is what is called as the locomotor brachialis. Then followed by that, the blood pressure. If you observe the blood pressure, there will be increase in the systolic blood pressure, and there will be gross decrease in the diastolic blood pressure. So because of increase in systolic blood pressure and decrease in diastolic blood pressure, there will be wide pulse pressure. And what you have to understand is that the increase in systolic blood pressure is due to increase in stroke volume, and decrease in diastolic blood pressure is due to diastolic runoff. And very important point, you take this Korotkov sounds. These Korotkov sounds, they are being heard even at 0 millimeters of mercury also. Then what is that you consider the diastolic blood pressure? So whenever you are deflating the sphygmomanometer, the point at which, right, the point at which you have muffling of the Korotkov sounds, that is your phase 4. That is your phase 4. This muffling of the Korotkov sounds, this usually it corresponds to the diastolic blood pressure. Right, this usually corresponds to the diastolic blood pressure. Okay, so that is about the measurement of the blood pressure. And you need to understand a very important sign called as the main sign. So what is this main sign is? That is decrease in diastolic blood pressure of 15 millimeters of mercury when the arm is held above the head. Right, when the arm is held above the head, the diastolic blood pressure, it will fall up to 15 millimeters of mercury. Decrease in diastolic blood pressure of 15 millimeters of mercury when the arm is held above the head, that is called as the main sign. Next is the Corrigan sign. What is this particular Corrigan sign is, you can observe the dancing carotids within the neck. Right, you can observe the dancing carotids within the neck. Why is that dancing carotids you are having? So you have that prominence of the carotid during the systole, and there will be diastolic collapse, right? So prominence during systole, collapse during diastole, and that we call it as the dancing carotids, which is called as the Corrigan sign. Next is the Demoset sign. What is this Demoset sign? Demoset sign is the to and fro movement of the head with each cardiac cycle. That is what is called as the Demoset sign. And next is the Landolfi sign. Now you just observe carefully, we are just moving in a very systematic manner. Quincke sign, that is in the digits, prominent digital artery pulsations, then Corrigan's pulse or water hammer pulse, then wide pulse pressure in the blood pressure, then we have discussed locomotor brachialis, then dancing carotids, that is your Corrigan sign. Next is the Demoset sign, which is to and fro movement of the head. Now you just see within the face, that is mainly in the eye, you have two signs. One is Landolfi sign, where there is change in the pupil size. Right, there is change in the pupil size with each cardiac systole. That is what is called as the Landolfi sign. Change in pupil size with each cardiac systole is known as the Landolfi sign. Next is the lighthouse sign. Lighthouse sign is that which you see over the forehead. So over the forehead, you will notice that there is flushing and as well as blanching over the forehead. Right, flushing and as well as blanching over the forehead with each cardiac cycle is called as the lighthouse sign. Next we have the Becker sign. Becker sign is the pulsations in the retinal artery. Right, pulsations in retinal artery, this is what is called as the Becker sign. Okay, so one is lighthouse sign over the forehead, Landolfi sign within the pupil, Becker sign within the retinal artery. Then Muller sign. So Muller sign is that you observe the pulsations within the uvula. Right, you ask the individual to widely open the mouth and then you observe the uvula. So you will notice that there is pulsations over the uvula, and that is what is called as the Muller sign. So you have totally 4 important signs over the face: lighthouse sign over the forehead, Landolfi sign the pupil, then Becker sign retinal artery, and Muller sign the uvula. Then you take the abdomen, Rosenbach sign and Gerhardt sign. Rosenbach sign is the pulsations over the liver with each systole and as well as diastole, and Gerhardt sign is the pulsations that you observe over the spleen. Right, then you take over the lower limbs. We have what is called the Traub sign, where you will listen the pistol shot sounds. Right, where you will listen a pistol shot sounds. Okay, so these are basically the booming sounds which are being heard over the femoral artery by the placement of the stethoscope. Right, once you place the diaphragm of the stethoscope and you press the femoral artery, you will listen this booming sound or pistol shot sound, which is called as the Traub sign. Next thing is the Durosis sign and as well as the Durosis murmur. So let us just assume this is the femoral artery, and over the femoral artery you have placed the diaphragm of the steth. Right, and after placing this diaphragm of the steth, if you compress the diaphragm proximally, then the murmur that you get is the systolic murmur over the femoral artery, whereas if you compress the diaphragm distally, then what you get is the diastolic murmur. right, what you get is the diastolic murmur once you compress the steth distally. Okay, that is diaphragm distally. And this distal diastolic murmur, this is called as Durose's murmur. And when you take both of them together, that is systolic murmur and diastolic murmur together, that is called as Durose's sign. That is called as Durose's sign. So this is about the Durose's murmur and as well as Durose's sign. Next we have what is called the Hill's sign. Now if you take the systolic blood pressure in the brachial artery and systolic blood pressure within the femoral artery, the difference will be 10 millimeters of mercury, right? In the femoral artery, the systolic blood pressure will be almost 10 millimeters of mercury more than compared to that of the brachial artery within the upper limb. That is a normal phenomenon. But what is the Hill sign is, if the difference between the systolic blood pressure of the femoral artery and as well as the brachial artery, if the difference is more than 20 millimeters of mercury, right, if the difference between the systolic blood pressure in the femoral artery and as well as the brachial artery, if it is more than 20 millimeters of mercury, that we call it as the Hill sign. And the Hill sign, it also tells you about the severity of, right, it also tells you about the severity of the aortic regurgitation. So in case of a severe AR, how much will be the Hill sign? That will be more than 60 millimeters of mercury. That is what you will observe in the severe AR. And this Hill sign, it is a very specific sign of the aortic regurgitation. And next important sign is the Shelley sign. This is observed commonly in females, right? That is pulsations that you will observe or you will be able to make out over the cervix. That is called as the Shelley sign in case of the aortic regurgitation, right? Okay, now these are all the peripheral signs that you come across only in case of chronic AR. But whereas in case of acute AR, what did we discuss? You don't have that increased stroke volume, and that is the reason why you don't have the peripheral signs in case of the acute AR. So these are all the peripheral signs starting all the way from the tip of the finger. Quincke's, prominent digital artery pulsations, Corrigan's pulse, wide pulse pressure, locomotor brachialis, Corrigan's sign, Demoset sign, that is up to head. Then Landolfi sign, Becker sign, Muller sign. Then we also have Lighthouse sign, right? These are all the ones which are seen in the face. Then Rosenbach sign and Gerhardt sign in the abdomen, right? Whereas the remaining all, you take the Hill sign, Trop sign, Durose's murmur. These are the ones which are seen over the lower limbs. Shelley sign over the cervix. Main sign, it is again the diastolic blood pressure decreasing by 15 millimeters of mercury when you raise the arm above the head. So these are all the peripheral signs which are seen only in case of the chronic AR, and more is your peripheral signs, more severe is your aortic regurgitation. Now then followed by that, you need to know, like when you palpate the precordium in case of the chronic AR, what will be the manifestations. So if you take the apical impulse, it is shifted down and out. So it is heaving type of the apical impulse, and this heaving type of apical impulse, it is shifted or it is displaced, right? It is displaced inferiorly and as well as the laterally, right? It is displaced inferiorly and laterally. So that is what is the position of the apical impulse. Now why is that? That is because of increase in the LV end diastolic volume causing increase in your LV size, right? And when you palpate the apex, you will also notice that there is systolic expansion and diastolic retraction. So the systolic expansion and diastolic retraction, they are very prominent over the apex, right? They are very prominent over the apex. And the next is the thrill. So what exactly is the thrill? Thrill is nothing but the palpable murmur, right? They are nothing but the palpable murmur. So this diastolic thrill, you will be able to palpate in a thin built individual. And where exactly you will be able to palpate this diastolic thrill? That is along the left sternal border, right? So this thrill is because of the regurgitation of the blood from the aorta into the left ventricle. And there will be also prominent systolic thrill, right? This systolic thrill you classically observed in the suprasternal notch, right? You will classically observe that in the suprasternal notch. So that will be the systolic thrill. Okay, so diastolic and as well as the systolic thrill that can be made out on palpation. Now, why is that you are getting this systolic thrill? Because when the left ventricle contracts, there is increased volume of the blood which is entering into the aorta. So the aortic valve, it behaves as the functional aortic stenosis. Actually, there is no true obstruction, but for this large volume of the blood which is coming out of the LV into the aorta, the aortic root behaves as that there is functional aortic stenosis. Okay, right. Now coming to the auscultation in patients with the aortic regurgitation. Auscultation, right, if you see, this is your first heart sound, then second heart sound, then you have first heart sound again. So between S1 and S2 is your systole, between S2 and S1 is your diastole. A2, it is soft or absent in aortic regurgitation because there is incomplete coaptation of the valves. There is valve closure is not there. So A2 will be absent, right? And the next important point is, if the aortic regurgitation is due to bicuspid aortic valve, then you will listen a systolic ejection sound, right? You will listen a systolic ejection sound if the aortic regurgitation is due to bicuspid aortic valve, right? And occasionally you can also listen the fourth heart sound. So what is the mechanism of the fourth heart sound? That is due to increased contraction of the left atria, right? Forcible contraction of the left atria. Why is that there is forcible contraction in this individual? Particularly if you take bicuspid aortic valve, the individual will also develop aortic stenosis. So once there is development of aortic stenosis, there is gross increase in the LV end diastolic pressure. So atria, if it has to send the blood into the ventricle, there should be a stronger left atrial contraction. So because of the stronger left atrial contraction, these patients, they develop what is called S4 may be heard. Okay, so that is about the auscultation in patients, the heart sounds related to the AR. And one more point, as such in AR, if there is development of left ventricular failure, you will also listen the S3, right? You will also listen the S3. Then followed by that, the murmurs in aortic regurgitation. So you have early diastolic murmur, you have mid systolic murmur, and then you also listen a mid diastolic murmur as well. Now, you take the concept of the early diastolic murmur. That is because of the regurgitation of the blood from the aorta into the left ventricle. And the murmur of early diastolic murmur, remember, it is a high pitched murmur, right? It is a high pitched murmur and high pitched blowing murmur. And this early diastolic murmur of AR, remember, it is decrescendo diastolic murmur, right? It is decrescendo diastolic murmur. And this early diastolic murmur of AR, it is best heard in left third intercostal space in the parasternal line. That is about the what do you mean by the word decrescendo murmur? That is, initially the intensity of the murmur is very high and gradually slowly it decreases. So that is about the quality of the early diastolic murmur, right? Whereas in those individuals who have the mild aortic regurgitation, the murmur, it is very brief. And see, the early diastolic murmur, loudness and as well as duration, it completely increases on the severity of the aortic regurgitation, right? If it is like very severe, it can be indeed the holodiastolic as well, right? It can be indeed the holodiastolic as well. Now, what should be the position of the patient to listen this particular murmur? See, you need to place the diaphragm of the stethoscope, right? You need to place the diaphragm of the stethoscope in patient sitting position, right? In patient sitting up position and leaning forward, then the intensity of the murmur that you listen is good. and the breath of the individual should be held in expiration, right? The breath of the individual should be held in expiration. And what you have to understand that is, in patients in whom AR is caused by primary valvular disease, the diastolic murmur, it is usually louder along the left sternal border than right sternal border. Why left sternal border? Because you are having regurgitation from the aorta into the LV. So that is the reason why the murmur is more louder if it is due to valvular pathology on the left sternal border. But right, left sternal border if it is due to valvular pathology. But this particular murmur of aortic regurgitation, it is louder on the right sternal border if the aortic regurgitation is due to the aortic root dilatation. So if it is like aneurysmal dilatation of the aortic root causing aortic regurgitation, then it is right sternal border, the murmur will be loud. So please remember, aortic valve pathology causing AR, the murmur is loud on the left. Aortic root pathology causing AR, the murmur is heard loud over the right. Concept is very simple, because the valve causing regurgitation more located over the left sternal border. Aortic root, that is ascending aorta, it is present over the right sternal border. So that is the reason why the murmur that you listen is loud on the right sternal border if the AR is due to aortic root dilatation or aneurysmal dilatation. And even you take the quality of the murmur, if the aortic regurgitation is due to the eversion of the aortic cusp, right? So if the aortic regurgitation, if it is due to eversion of the aortic cusp, right, if it is due to eversion of the aortic cusp causing aortic regurgitation, and what do we describe the quality of the murmur as? We describe this as cooing or the musical diastolic murmur, right? Cooing or the musical diastolic murmur. Okay, so that is about the description of early diastolic murmur. So remember, early diastolic murmur, it is a high pitched murmur which is of blowing quality, which is of decrescendo pattern, and it is being heard in the left third intercostal space, parasternal line, and it is loud on the left third intercostal space if the aortic regurgitation is due to aortic valve pathology, and it is best heard in the right sternal border if the aortic regurgitation is due to the aneurysmal dilatation of the aorta. And this particular murmur, it is loud, and even the duration is also increased as the severity of the aortic regurgitation increases, and you need to place the steth of the individual in sitting up position of the patient with slightly leaning forward, and you have to hold the breath of the individual during expiration, during which the intensity of the murmur also increases. And if there is eversion of the aortic cusp, then there will be cooing or the musical quality of the murmur. Okay, so this is about the early diastolic murmur, which is a true murmur or a primary murmur of AR. And the other murmurs are the mid-systolic murmur. Now, why do you get this mid-systolic or the ejection systolic murmur? Remember, this is heard best at the base of the heart. So, and here there is actually no true obstruction of the aortic valve. There is no true obstruction of the aortic valve, but the aortic valve, it behaves as the functional aortic stenosis, because in aortic regurgitation, because of regurgitation of the blood into LV, there is increase in your LV end diastolic volume. So that increased LV end diastolic volume, that will cause the increased stroke volume. Stroke volume is grossly increased. So to that increased stroke volume, the aorta, it behaves as the functional aortic stenosis, right? And in functional aortic stenosis, the murmur that you listen is the mid-systolic murmur, which is also called the ejection systolic murmur. Okay, next is the mid-diastolic murmur. Now this mid-diastolic murmur of AR, right, this is nothing but the Austin Flint murmur. Now why do you get this Austin Flint murmur is that whenever there is the regurgitation of the blood, this regurgitation, if it is like severe AR, this regurgitation will hit the anterior mitral leaflet of the mitral valve. So thereby this anterior mitral leaflet, right, it is shifted towards the posterior mitral leaflet. So once the anterior mitral leaflet comes very close to your posterior mitral leaflet, mitral valve, it behaves that there is mitral stenosis. So for the movement of the blood from the left atrium to the left ventricle during the diastole of the left ventricle, there is functional MS, and in MS the murmur what you listen is the mid diastolic murmur. So that mid diastolic murmur that you listen in case of the severe AR, remember it is the functional murmur, which is also called as the Austin Flint murmur. So that is due to diastolic displacement of anterior leaflet of the mitral valve towards the posterior mitral leaflet, and the mitral valve will behave as the functional mitral stenosis. Then coming to dynamic auscultation in case of AR. So dynamic auscultation, if you observe, any maneuver which will increase the afterload on the left ventricle, that will cause increase in the intensity of the murmur. What are those maneuvers? Like hand grip will increase the afterload on the left ventricle. Strenuous exercise, there will be increase of the afterload over the left ventricle. So once there is increase in the afterload on the left ventricle, more and more regurgitation occurs, and thereby there will be increase in the intensity of the early diastolic murmur. So basically the concept is hand grip and as well as strenuous exercise will increase the afterload, thereby it will increase the regurgitation, causing increase in the intensity of the murmur. Whereas you take the auscultation in case of the acute AR. In case of acute AR, what is that we have discussed that there is early increase in the LV and diastolic pressure, right? Why? Because left ventricle is not in a position to handle that increased volume of the blood. So there is early increase in the LV and diastolic pressure. This early increase in LV and diastolic pressure, that will cause the early closure of the mitral valve. And this early closure of the mitral valve, that will make the individual to develop a soft S1, right? That way the individuals will have soft S1. And in these patients with acute AR, even the pulse pressure is also normal. In chronic AR, we have discussed that there is wide pulse pressure, but in these individuals, the pulse pressure is also not wide. And these patients, they have the early diastolic murmur, but it will be a very short early diastolic murmur. That is the auscultation in case of acute aortic regurgitation. Now, let us discuss the investigations in patients with AR. That is ECG, 2D echo, and as well as chest X-ray. These are very, very important, right? Now, what will that ECG shows? So, first if you observe the ECG. So, ECG, you will have the signs suggestive of the left ventricular hypertrophy. But here, what you will observe is the volume overload. That is what you will observe in the ECG changes. So now what will be that ECG changes is, number one, you will notice the LV strain pattern. What will be that LV strain pattern? That is in lead 1, AVL, V5 and as well as V6. You will observe that there is ST segment depression and there will be also asymmetrical T wave inversion. So ST segment depression and asymmetrical T wave inversion is very much suggestive of the LV strain pattern, and there will be also left axis deviation, and the point suggestive of left ventricular hypertrophy is there will be SV1 plus RV6, right? That will be more than 35 mm. So this is what is your Sokolov-Lyon criteria for determining the left ventricular hypertrophy. So this is about the ECG. Then what will be the changes in the 2D echo that you will observe? In the 2D echo, you will notice you will determine the LV size. What will happen to the LV size? That is increased. And these patients, the systolic function will be normal in early stages of the aortic regurgitation, but as the severity of the aortic regurgitation increases, the myocardial contractility, right, the myocardial contractility decreases. So there will be left ventricular dysfunction. So these patients, they develop heart failure with reduced ejection fraction. Okay, basically it is nothing but the systolic dysfunction. And another important point that you will observe is the diastolic fluttering of the anterior mitral leaflet. Okay, diastolic fluttering of the anterior mitral leaflet. So this diastolic fluttering of the anterior mitral leaflet, right, it is rapid and having a high frequency. Rapid and having a high frequency. So this rapid high frequency diastolic fluttering of anterior mitral leaflet, which is being produced by the impact of the regurgitant jet, is the characteristic findings in patients with the aortic regurgitation. And this 2D echo is also useful in determining the etiology of the aortic regurgitation, right? Is it like the aortic valve leaflet problem, or is it aortic root problem that can be determined by the echocardiogram, right? What will be the echo findings in case of the severe aortic regurgitation? Now, if you observe the central jet of the AR, which is coming from the aorta to the left ventricle, the central jet of the AR, it is being assessed by color flow Doppler. Right, it is being assessed by the color flow Doppler. So this color flow Doppler will show that this aortic regurgitant jet, it occupies almost 65% of width of left ventricular outflow tract, right? It occupies almost 65% of the left ventricular outflow tract. Okay, so that is the diameter of the central jet. Now, how much will be the regurgitant volume in case of severe AR? That will be more than or equal to 60 ml per beat. And if you take the regurgitant fraction, that will be more than or equal to 50% of the normal. Okay, so regurgitant fraction is more than or equal to 50%. And in the descending thoracic aorta, right, in the descending thoracic aorta, you will observe that there is diastolic flow reversal. Okay, and this diastolic flow reversal will happen in the proximal portion of, right, in the proximal portion of the descending thoracic aorta. And when will this happen? During the diastole. And the next important is about the deceleration time. There will be, when you apply the continuous flow Doppler across the aortic valve, you will notice that there is rapid deceleration time in patients with acute AR. So first of all, you should understand what is this deceleration time. Okay, so deceleration time in 2D echo, it refers to the time it takes for the blood flow velocity in the left ventricle to decrease to its lowest point during the diastole. That is what is called deceleration time. I'll repeat again. It refers to the time it takes for the blood flow velocity in the left ventricle to decrease to its lowest point during the diastole. And this deceleration time, it tells you about the diastolic function of the left ventricle. So what you have to understand is that longer is the deceleration time, right? Longer is the deceleration time. That tells the individual is having the normal or mild decrease in the diastolic function, or there is mild diastolic dysfunction. But if suppose if there is shorter deceleration time, right, if suppose there is shorter deceleration time, that suggests that there is impaired relaxation of the left ventricle, right, there is impaired relaxation of the left ventricle causing severe diastolic dysfunction. That is what is your deceleration time. Okay, so shorter is the deceleration time, severe is your diastolic dysfunction, right? Longer is your deceleration time, normal, or there is mild diastolic dysfunction. Then followed by that, the cardiac MRI. Now, in which group of individuals we need to do the cardiac MRI? In those individuals who have the poor acoustic window, where you are unable to make out the aortic valve or aortic root and where you are unable to make out the CVRT, in them you need to do the cardiac MRI. So cardiac MRI, it will be very much useful in the assessment of the aortic size, right, and it will be also very much useful in the assessment of the aortic contour. And this cardiac MRI, it is also utilized for screening of left ventricular fibrosis, right. It is also useful for screening of left ventricular fibrosis, and the screening of the left ventricular fibrosis can be assessed by gadolinium enhancement, and there will be late gadolinium enhancement. Okay, LGE stands for late gadolinium enhancement. That will tell you that there is left ventricular fibrosis. And this cardiac MRI and as well as the CT, both of them will provide detailed assessment of the aortic valve and as well as the aortic root anatomy. So it is very much useful whenever there is poor acoustic window. And the other investigations are transesophageal echocardiography and as well as three-dimensional echocardiography. So this transesophageal echocardiography, this will give you detailed anatomical assessment of the valve, right, detailed anatomical assessment of the valve. It will give you detailed anatomical assessment of the root, and it will also give you detailed anatomical assessment of the portions of the aorta, that is ascending aorta, arch and as well as the descending. All of these, they can be clearly made out by your transesophageal echocardiography, whereas your three-dimensional echocardiography, it is useful for measurement of the LV volumes, right. It is useful for measurement of the LV volumes. So that is about your imaging. And next important imaging is the chest X-ray. Whenever you do a chest X-ray, what is that you will observe in the apex is, you find that the apex, it is displaced downwards, right. And why is that? That is because of LV volume overload causing left ventricular dilatation. So it is displaced down and as well as left, right, down and as well as left. Okay, so this displacement of apex down and left, that you can see in the frontal projections. But when you take the chest X-ray in left anterior oblique and as well as in the lateral projections, you will notice that LV is also displaced posteriorly, right. LV is also displaced posteriorly and it is encroaching the spine. LV is displaced posteriorly and it is encroaching the spine. Now, if the aortic regurgitation is caused by the problem in aortic root, then in the chest X-ray, you will also be able to make out the aneurysmal dilatation of the aorta, right. You will be also able to make out aneurysmal dilatation of the aorta, and whenever there is aneurysmal dilatation of the aorta, that will fill the retrosternal space, right, that will fill the retrosternal space in the lateral view. Okay, so that is about the chest X-ray. So in the frontal projection, you will notice that the apex is displaced down and out, that is down and left, and in the LAO and as well as lateral projections, you will be able to make out that the LV is displaced posteriorly and approaching the spine, and aortic root, you find that there is aneurysmal dilatation of the aorta and occupying the retrosternal space. And you have to know that the 2D echo, cardiac magnetic resonance imaging and as well as the CT angiography, they are sensitive then compared to that of the chest X-ray in determining the aortic root and as well as the ascending aortic enlargement. These three are more sensitive than compared to that of the chest X-ray. And next important investigation is cardiac catheterization and as well as the angiography. So the left and as well as the right cardiac catheterization with the contrast, right, with the contrast, that will provide the confirmation of magnitude of aortic regurgitation. Okay, definitely the cardiac catheterization is a confirmatory investigation, but it is an invasive procedure. We don't do this in all the individuals. So this will confirm the magnitude of aortic regurgitation, and it will also tell you about the status of the LV function. That is the importance of the cardiac catheterization and as well as the angiography. And what about the coronary angiography? See, coronary angiography as such it is not required, because when you are doing CT arteriography, it will tell you about the coronary arteries. But as routine process, like for example, you are taking a patient to the surgery, right? You made out that in 2D echo and as well as the cardiac magnetic resonance imaging, you have completely come to a conclusion that you want to go ahead with the surgery. In such case, you need to do the coronary angiogram. See, coronary angiogram is performed routinely in appropriate patients prior to surgery to look for how are the coronary arteries in detail by the coronary angiogram. Otherwise, we don't do coronary angiogram if we are not planning for any CABG. Okay, so that is about your investigations. So 2D echo, cardiac magnetic resonance imaging, CT angiography, then 3D echo and transesophageal echocardiography, chest X-ray, and then the cardiac catheterization and as well as the angiography. Right? Now, we will discuss in detail about the treatment of the aortic regurgitation. So, coming to the treatment of aortic regurgitation. So, we have an acute AR and then the chronic AR. So, how do you treat the acute AR? Like we have two options, one is drugs and the other one is the surgery. But remember, the definitive treatment for the definitive treatment for the acute aortic regurgitation is the surgical treatment. Now, what about the drugs that we need to give? The drugs that we give is, we give intravenous diuretics. Why is that we give intravenous diuretics? Because these patients, they develop acute pulmonary edema. So, to wash out that acute pulmonary edema, we need to give the intravenous diuretics. And the other group of drugs that we need to give is the vasodilators. Okay. And by giving these drugs, once the individual is like slightly stable, then you can plan for the surgical correction of the aortic valve or the aortic root, because the most common cause for acute AR is what? That is the trauma, next is the infective endocarditis, and next is the aortic dissection. So you have to treat accordingly once the individual is like slightly stable medically. And you have to remember that beta blockers and as well as IABP, they are absolutely avoided in patients with the acute AR. Why is that? Because if you take the beta blockers, what these beta blockers will do, they decrease the heart rate and thereby they increase the diastolic filling time of the ventricle. Okay, so now that means whenever you are giving beta blockers, that is making the ventricle to stay in the diastole for longer time, and thereby there will be more and more regurgitation from the aorta. So aortic regurgitation get precipitated whenever you are giving beta blockers. And in the same way, your IABP is also avoided or contraindicated. What the IABP does, the IABP, it increases the diastolic pressure of the aorta, and thereby it increases the myocardial perfusion. Actually, the indication of the IABP is like cardiogenic shock in order to increase the myocardial perfusion by increasing the diastolic pressure of the aorta. But what happens in case of the aortic regurgitation is that whenever there is increase in the diastolic pressure of the aorta, the aortic regurgitation, it gets precipitated. That is the reason why the IABP, it is absolutely contraindicated in patients with the aortic regurgitation. And coming to the chronic AR, like here also we have surgical options and as well as the medical management. But for acute AR, remember, surgery is the treatment of choice, and that surgery has to be done within 24 hours of the onset of the symptoms. So for chronic AR, remember, we have surgery and as well as the medical management. These are the two important options. So you take the medical management or you take the first surgical management. What is the indication for doing the surgical management is, number one, there should be onset of the clinical features of the aortic regurgitation, and number two, there should be a development of LV systolic dysfunction. So these are the two strong indications for doing the surgery. Now, if you take the medical management, what is that we give is the diuretics is one group of drugs, and the other group of drugs is we give the vasodilators. And the vasodilators that we give is the ACE inhibitors, then angiotensin receptor blockers, and then the hydralazine. Right, then hydralazine. So these are the vasodilators. They may be useful for temporarily stabilizing the patient. right? And once the individual is like stabilized medically, then the patient can be planned for surgery. But very important thing is there are two important events which can precipitate the symptoms of the aortic regurgitation. One is cardiac arrhythmias and the other one is the development of the infections. So development of cardiac arrhythmias and as well as systemic infections, they are poorly tolerated. That can precipitate the symptoms of the aortic regurgitation. So that is the reason why the cardiac arrhythmias and as well as the infections, if at all they develop, they have to be treated promptly and as well as the vigorously. And another point you have to remember is that if the individual is asymptomatic, then surgery is not required. But there are few indications where even though they are asymptomatic, surgery is required, I will tell you. But if that parameters are not there, if the individual is asymptomatic, then surgery is not required. Only diuretics and as well as vasodilators will suffice. Now, is there any role of nitroglycerin in aortic regurgitation? There is no role. And if the aortic regurgitation is secondary to syphilis, then you need to give full course of penicillin to the patient. Okay. Next, coming to the Marfan syndrome and as well as the connective tissue disorders. So if the aortic regurgitation is secondary to Marfan syndrome, what has been found is you need to give beta blockers and you also need to give the angiotensin receptor blocker, that is losartan. Why is that we need to give beta blockers and as well as losartan is these two drugs, they have been found that they reduce or they retard the rate of, right, they retard the rate of the aortic root enlargement, right? They retard the rate of the aortic root enlargement in young patients with Marfan syndrome. So that is the reason why beta blockers and as well as losartan has to be given in these individuals. Whereas in bicuspid aortic valve and as well as Takayasu, there is no role of, right? There is no role of beta blockers and as well as losartan. And one more important point, if the development of aortopathy, if the aortopathy is causing the aortic regurgitation, in this group of individuals, the isometric exercises, they have to be avoided because these isometric exercises, they can precipitate the symptoms of AR. So that is the reason why in patients with aortopathy causing AR, isometric exercises should be avoided. Then what about the surgical treatment? So whenever you are doing surgical treatment, you have to keep two things in your mind. So what you have to remember is the patients, most of these patients with the AR, they become symptomatic after the development of the LV systolic dysfunction. So once the individual is symptomatic, you have to plan for surgery because the patient has developed the LV systolic dysfunction. Now, the surgery after the development of LV systolic dysfunction, after the development of the symptoms, the surgery should not be delayed. So, delayed too long means it is defined as if the surgery is delayed by more than 1 year after the development of symptoms, after the development of LV systolic dysfunction, even though you do surgery, right, the surgery does not restore the LV function. Right, surgery does not restore the LV function. So that is the reason why surgery should not be delayed too long after the development of symptoms and after the development of LV systolic dysfunction. So that is the reason why those individuals who are asymptomatic and those individuals who are having normal LV systolic function, they have to undergo monitoring every 6 to 12 months. They have to undergo the 2D echo and they have to be assessed how is the LV systolic function, so that once you pick up the patient in early stages, once you do a surgery early, then the outcome of the patient may be good, right? And the other point is you need to do the exercise testing. Now, what is the purpose of doing this exercise testing? Exercise testing will be helpful to assess the effort tolerance. That is the reason why you need to do the exercise testing. Now, you take the indications for the aortic valve replacement. Very important. The class 1 indication is the severe symptomatic AR. That is a class 1 indication. What about asymptomatic severe AR? Even asymptomatic severe AR, they also have to undergo the aortic valve replacement. But before that, let me tell you, once the individual develops severe symptomatic AR, even though there is normal LV function, still you have to make the individual to go ahead with the surgery. In spite of normal LV function, the symptoms are there, then they definitely have to undergo surgery. Now, what about the asymptomatic severe AR? Asymptomatic conditions when they have to undergo the aortic valve replacement is when the ejection fraction is reduced to less than 55%, they have to undergo aortic valve replacement. And if LV end systolic dimension, if it is more than 50 mm, that is also the indication for the aortic valve replacement. And if LV end diastolic dimension, if it is more than 65 mm, even though there is asymptomatic AR, that is also indication for surgical treatment. So that is about the asymptomatic patients who have to undergo surgery. Now, you take the other scenario. You are doing the follow-up every 6 to 12 months. There is progressive increase in the LV size and there is progressive LV systolic dysfunction. Then also these patients, they have to undergo surgery. And what about the role of the TAVI in case of the aortic regurgitation? What is TAVI? That is transcatheter aortic valve implantation. So this particular TAVI, remember, it is not recommended in case of the aortic regurgitation. So it is recommended in case of the aortic stenosis, but not for the aortic regurgitation. Now, if you take the surgical options in aortic regurgitation, we have mechanical and as well as bioprosthetic valve replacement, surgical repair of the aortic valve, then aortic root reconstruction. So if you take this mechanical and as well as the bioprosthetic valve, remember, they are generally necessary in patients who are having the development of aortic regurgitation of rheumatic origin. If it is rheumatic cause for aortic regurgitation, then they have to undergo this mechanical or the bioprosthetic valve replacement. Okay, right. And even for the other causes of AR, they are useful, but preferably for the rheumatic origin aortic regurgitation. And what about the surgical repair? See, if there is abnormality in the leaflet, like that there is perforation of the leaflet, right? If there is perforation of the leaflet due to infective endocarditis, or if there is rupture of the aortic valves, or if this particular aortic valves are being completely torn, then in such case the surgical repair may be possible. So wherever the place surgical repair is possible, just do surgical repair of the valve rather than complete aortic valve replacement. Now, what about the aortic root reconstruction? So if you take this aortic root reconstruction, so those individuals who have aneurysmal dilatation of the aorta, or who have the dilatation of the proximal ascending aorta, in them you have to do the aortic root reconstructive procedure, where what is that reconstructive procedure? You have to see that the annulus is being repaired, right? The annulus is being repaired. And what is that annulus is being repaired? You need to do the narrowing of the annulus. So basically what you have to do is you need to do the excision of the portion of the aortic root or the aorta which has been dilated, and you need to place the graft. Okay, so elective valve sparing. So when will you do valve sparing? That is when only there is involvement of the aortic root dilatation. Then valve sparing aortic root reconstruction generally involves reimplantation of the valve in a contoured graft with reattachment of the coronary artery buttons. So you can see that here. So this is reattachment of the coronary artery buttons into the side of the graft. So the valve, the native valve will be there, but the aortic root, whichever is being dilated, it has to be excised, and you need to place the graft, and onto this particular graft you need to button the coronary arteries back. So that is about the reconstructive procedure if there is abnormality within the aortic root. Now, what are the mortality rates after doing the aortic valve surgery? Remember, it all depends upon whether you are doing isolated aortic valve replacement, or along with aortic replacement you are also doing CABG. So if it is isolated aortic valve replacement, the mortality, it has been done in some of the studies which has shown is the mortality is, the post-operative mortality is found to be 2%. Whereas if it is along with aortic valve replacement, you are also doing coronary artery bypass graft, then the mortality is being found to be around 3.5 to 4%. Okay. So these mortality risks, they are largely dependent on the stage of the disease, right? It completely depends upon the stage of the disease, and it also depends upon the LV function at the time of surgery. So these are the two things which will decide the post-operative mortality. And however, you have to remember that patients with AR, marked cardiac enlargement is there and established LV dysfunction, it has been found that the operative mortality is around 10%. Okay, that is, at the time of surgery, if there is significant LV systolic dysfunction, the chance of post-operative mortality is nearly around 10%. So that is about the surgery. So surgery, like we have the mechanical or bioprosthetic valve replacement, then surgical repair in case of infective endocarditis causing perforation or trauma causing tearing of the aortic valve, and the third important is the reconstructive procedures. Now finally, if you take this aortic regurgitation, it can occur due to primary valve pathology or the aortic root pathology. And if it is secondary to infective endocarditis or trauma, it is acute AR, surgery is the treatment of choice. But the other causes will cause the chronic AR, so they can be treated medically. But if the individuals are symptomatically severe AR with chronic, then they have to undergo surgical treatment. And surgery should not be delayed too long, right? If the surgery is delayed too long, even though upon doing the surgery, the LV cannot be recovered back. So now you see here, severe AR, right? Severe symptomatic AR, that is the class 1 indication for doing the aortic valve replacement. If the individual is like asymptomatic severe AR, if the ejection fraction is reduced to less than 55%, it's a class 1 indication for surgery. And along with that, asymptomatic severe AR, the undergoing coronary artery bypass graft, that is also class 1 indication for doing the aortic valve replacement. And if suppose if the ejection fraction is more than 55%, LV end systolic diameter is like more than 50 mm, then aortic valve replacement has to be done, but that is class 2 indication. And if there is like progressive changes, right, that is ejection fraction is around 55 to 60% and end diastolic diameter is more than 65 mm and the patient is having low surgical risk, aortic valve replacement has to be done, and that is a class 2B indication. And moderate AR, that is also a class 2 indication. So that is about in which group of individuals you have to do surgery is very, very important, that you need to be very much aware of. So thank you very much. This is about the aortic regurgitation.